Brian, the four of us are going to take over.
Okay.
We're waiting for you.
All right. Okay, so we're going to call the meeting to order. Roll call, Madam Clerk.
Calling the roll, Ms. Simon.
Here.
Ms. Brown.
Here.
Mr. Jones.
Here.
Mr. Schrein.
Here?
Mr. Brady.
Here.
There is a quorum.
Thank you. Any comment? Public comment?
No, Madam Chair, no one is signed in.
We have minutes from July 18th. Is there a motion to approve the
So
minutes?
moved.
Second. These minutes are from July 18th. All in favor? Aye. Okay. One piece of legislation referred to committee. And can we have that read for the record, please, Madam Clerk?
Resolution number 2018-0162, authorizing a revenue-generating agreement with Case Western Reserve University as fiscal agent for first-year Cleveland in the amount not to exceed $774,940 for expansion of the Moms First program in connection with the Invest in Children program for the period 1/1/2018 through 6/30/2019.
Hi.
Hi, good afternoon. Rebecca Dorman from the Office of Early Childhood, Invest in Children. Thank you for meeting for us today on this item. I'm here requesting your authorization to enter into this revenue-generating agreement with CASE in the amount of $774,940. The agreement runs through June 30th of next year, 2019. So this is really a pass-through of Medicaid dollars from the state coming to our community specifically to combat our very high and unacceptable rate of infant mortality. So the total amount passes through Invest in Children and goes to the Moms First program to allow them to serve more children. And again, that program is administered by the Cleveland Department of Public Health. It's in its 28th year of operation, supporting high-risk expectant mothers living in the city limits. The program starts during pregnancy and continues until the child's second birthday. A great deal of emphasis is put on early and adequate prenatal care, healthy pregnancy, healthy birth outcomes. They have excellent, I'm very pleased to say, very, very excellent outcomes in terms of the infant mortality rate. It is funded primarily by the federal government. It's this long-time grant, 28 years. But in addition to that, the city of Cleveland puts in dollars. And since 2006, the county has been putting some HHS levy dollars into the program again to make it available to more women. So our contribution, which you've already approved in the past, is $366,345 per year. Annually, this program is serving in total 1,680 moms. This additional amount in the contract, the pass-through dollars from Medicaid, will be added to our existing contract. We'll be back with an amendment, and will enable Moms First to serve an additional 150 mothers. This is the second year that Medicaid funding has been made available to us from the state. Last year, it was $472,700. As you see this year, quite a bit more dollars over an 18-month period. So I'll stop and see if I can provide you with any. And I have a whole cast behind me to help answer details if you have specific questions.
So we'll entertain questions, the first from Councilwoman Brown, and then maybe you can do a quick intro, even though we know most of everybody
Most of
here.
the players, okay, sure.
Mine is relatively easy. The resolution states an additional 175 families, but you stated 150, so I just wanted to get clarity to make sure we have that right on the record.
So it's 175? Okay, so the resolution is correct. My talking points were wrong.
Okay, all right. Thank you very.
Sorry about that.
Sure.
Councilman Jones?
I was curious as to if you're aware of the universe of mothers that are may potentially need service out of the 1,680 served.
So would we say the 7,000 approximately on Medicaid in the city? So I'm going to introduce Lisa Matthews, who's director of the program. Lisa, what do you consider the total target population? Come up to the. This is Lisa Matthews, the longtime program director from inception, right? Almost?
1993.
Almost. So, long time program director.
Can you repeat, I wasn't quite
What's the
sure.
total universe of mothers that you would consider are in the target population that you serve?
Off the top of my head, I can't give you an exact number of births that occur in the city every year, but essentially every pregnant woman or adolescent within the city of Cleveland is, that is deemed at high risk is eligible for our services.
Okay. I imagine since we serve 1680, and they certainly have children who have, because of infant mortality, there have been lives lost. I was just curious as to if you had a sense of.
Well, we're serving, I can tell you it's about 40% of the population in need of our services, in terms of our capacity is able to serve about 40 to 45% of those.
Okay.
I can't put a
So
big
that's
figure on
around-
it, though.
But I think
Okay.
that's what I said, around
Right.
7,000 then, right?
Okay.
More or less. So there are about 15,000 births per year in the county, and I think half are Medicaid births. Do I have this right? At least. 50 to, I think 60% might be on Medicaid, if you consider, and then you have to go into what's in the city versus the rest of the county. I think countywide, so that's, I'm sorry.
So you target the Medicaid eligible.
Well, we target those at risk. They don't necessarily need, there's no income guidelines, so they don't need to be on Medicaid. Some are not, some are privately insured. However, we have some risk criteria. For instance, if you're an adolescent, you're automatically at high risk by virtue of the fact that you're an adolescent. If you've had a prior miscarriage or infant loss, you're automatically considered high risk. So there's a number of both social service as well as medical factors that can deem a participant or potential participant at high risk for a poor birth outcome.
Okay, thank you.
How's the population in the county and or city trending? Up, down, flat, newborns? Do you know? I mean, are we consistent at that
births-
number? Because you said what, 15?
It's about 15,000. I
Per
think a little bit down, a little below 15,000. Not much. That's from in the past decade or so since I started in my role. I would say it's trended down a little bit. Total births.
Interesting. Okay,
Yeah.
and what about
Teen births are down though overall, aren't they?
Yes, both.
Yeah,
teen
teen
and
births.
Overall births in the city of Cleveland are
Births are down.
do you have any factors that would be contributing to this?
Larks?
Factors that
We
might
like
be
looking at
impacting
flukes.
teen pregnancies?
Well, we would
Talk
like to.
talk into the microphone.
Thank you. We would like to think that it's partially, if not a great part, contributed to the initiatives of our local Ohio Equity Institute. So 3 years ago,
She's the co-chair.
with my colleague at the County Board of Health. About 5 years ago, the Ohio Department of Health formed what they call Ohio Equity Institute groups throughout Ohio in 9 communities that had the highest rates of infant mortality, Cleveland, Cuyahoga being one. And we were charged with developing a strategy, a 3-year strategy with both an upstream and a downstream approach to reducing infant mortality. And we chose to focus on, based on some local data, teen births in particular. And our upstream strategy means what we can do to prevent the pregnancy to begin with. And we decided to go with LARCs, which are long-acting reversible contraceptives. LARCs are an evidence-based approach to reducing unintended pregnancies. We know that an unplanned pregnancy is often an unhealthy pregnancy, so if we could reduce those unintended pregnancies, there'd be an impact on infant mortality. And in our community, we were successful over the 3 years in having same-day LARCs available at all of our federally qualified health centers and all of our healthcare systems throughout the county. One of the problems in the past was if they offered it, you couldn't get it the same day. There were issues with stocking it because the devices were expensive, issues with payment through Medicaid and so forth. And what would happen is by the time a young lady would come back for her appointment, after all that was worked out a month later, it would be too late. So that's been one of the broader initiatives. The other is centering pregnancy. That was our downstream approach, which is a group prenatal care model. So for those that do find themselves pregnant, again, centering is an evidence-based model that has shown to be effective in improving birth outcomes. So those women that go through the centering form those peer-to-peer supports with others of a similar gestation that are going through it with them. Their attendance rates at prenatal and postpartum appointments has increased tremendously. The education and support they receive has also helped with lower rates of preterm birth, longer durations of breastfeeding, you know, all the different indicators that we look at. So we like to think that the combination of those initiatives on top of the additional influx of dollars in our community around infant mortality prevention efforts have contributed to, and will continue to contribute long-term to a decrease in infant mortality.
And Moms First also does preconceptual, interconceptual planning with moms. So obviously they're there with the first pregnancy, but talking about planning for the second pregnancy. And the state has helped with Medicaid dollars for the expansion of centering as well, which is a lot more women to participate.
I just have a follow-up with regard to the Medicaid future in the state, the expansion in the waivers. Would that perhaps impact next year's dollars that would be funding this type of program, or anybody's guess? Yes?
So, yeah, I do not have a crystal ball on that. These dollars actually are coming from the 5 managed care organizations. How that all worked out at the state, I can't tell you exactly, but I think they were suggested they needed to help with infant mortality reduction, and those dollars became available. And yeah, we don't know what the future holds. I do think you should brag about your latest statistics in terms of the infant mortality rates Moms First has with the moms that so, I mean, they have excellent, why don't you tell them first, and you can talk and I'll hand them out.
So what Rebecca's handing out is our 2017 annual report that gives you a little synopsis of some of our activities. And in terms of our rates, what I can highlight for you is in the upper right-hand fuchsia color box, you'll see the infant mortality rates for 2017 for both the Moms First Project participants of 6.6 and then the City of Cleveland's rate of 13.3. Now that 13.3 is broken out at the top dark purple box on the left in terms of the racial disparity. It's made up of a black rate of 18.7 and a white rate of 6.8. So you can see there that it's highlighted the disparity between the black and white births is 2.75 times greater for black births than white births. Moms First goal is to reduce disparities in infant mortality, so about 80 to 85% of the participants we serve are African American. And given that I recently just spoke about the participants' eligibility based on a high-risk score, you would think that by us serving predominantly African American women that are at highest risk for poor birth outcomes, that our rate for our participants would actually even be worse than the black rate for the City of Cleveland of 18.7. And yet at 6.6, it's lower than the white rate of 6.8 for the City of Cleveland. So that really speaks tremendously to the impact of the program. The goal, the Healthy People 2020 goal is 6 infant deaths per 1,000 live births. And in 7 of the last 10 years, Moms First has been below 6. We actually had a blip here in 2017 at 6.6. But again, we're very proud of the impact that our program is having with high-risk pregnant women. Mm-hmm. And then there's just some other additional information you can read at your leisure about some of our activities, where we receive our referral sources from. The community liaisons are new staff that were actually hired as a result of this Medicaid money that we received, the initial award in 2016. And then the Ohio Equity Institute that I talked about, with the our initial upstream and downstream approaches of LARC and centering also has a focus on the 44128 zip code that's highlighted here as well. And that zip code was chosen because of its overlap between the City of Cleveland and the county, and the fact that it's a Cleveland County partnership in terms of us being co-chairs, that zip code, because of their high rates and the overlap between city and county, was selected as a priority that we're doing community engagement work in.
Good job, thanks.
Thank you.
Any other questions? So because of these flow-through dollars, there's really no impact on Health and Human Service Fund or general funds, so I'm gonna, okay, one more?
Oh.
Or what, you have a
If I
question?
may.
Go ahead.
Thank you, Madam Chair. Just a few questions. One, I had an opportunity to speak with the new CEO of Metro Health Hospital. And one stat that I threw out that I actually like you to hear your thoughts on is that I said that the Lee Harvard area was one of the largest infant mortality rate areas. Do you have a sense of zip code wise, or how you would characterize areas where infant mortality is highest, geographically speaking?
Well, so,
The hotspots.
I was gonna say.
So this is, I cannot tell you why. I think there are different ways of looking at the data, but this is the storyboard from First Year Cleveland, and they name Euclid, then Shaker Square, Buckeye, Shaker Heights, then Garfield Heights. Lee Harvard's not even, Lee Harvard's number 8 on this. I can show you this list. So I think there's been some differences in how people have calculated that, but I don't have a sense that anyone's done more than say they're hotspots and we need to pay attention. I don't know what you have.
So the way Moms First interprets the data is we look at infant mortality rates, but we also look at the number of births and number of deaths. So the infant mortality rate is calculated as deaths per 1,000 live births. So if you have a community that has a small amount of live births and they have maybe 2 infant deaths, their infant mortality rate could be very high, okay, because it's a small amount of births. Versus if you have a community, just say Glenville or a neighborhood that's a bigger community that has a lot of births and maybe they had 5 infant deaths, their rate could be lower than the community that had 2 because it's a rate per 1,000. So we don't just look at the rates and say, oh, this neighborhood here that has the high rate that had the 2 deaths is where we need to focus all of our effort. We look at where the larger amount of deaths are happening. And we staff Moms First according to that. That's how we look at, even though we cover the whole city of Cleveland, we don't canvass on Edgewater Drive, for instance, because that's not an area it's in. If someone needs our services there, we would serve them, but we focus our efforts and our staffing in the areas that need us the most. In 44128, because it is a special initiative through the Ohio Equity Institute, we have statisticians at the County Board of Health that have broken down that specific community by street and can tell you how many children died in this like that whole 44128 has more affluent areas and less affluent areas. And so they've broken it down and figured out which apartment complexes or which, areas are most at need in terms of targeting services. And with the data, there's the ability to do that. Now, to my knowledge, that has not been done to that level of detail in other communities at this point. We're just starting with that community, and based on the success of our reduction, and I'm preliminarily, we know that in 2017, and I might get this wrong, I probably shouldn't say it, but infant deaths have been reduced very much so in that zip code. And I don't know if we don't know yet the correlation between all of the work and this resident-involved group that's assisting with developing a plan for what can be done in 44128. But we're taking a look at it, and then based on its success, potentially could be looking at the rest of the community like that.
So by saying affluent or less affluent, what you're saying is that infant mortality is really impacts those who are less affluent.
Well, That might have not been the best choice of words. We have
And I'll-
homeowners and we have renters and we have areas, well, we know that poverty is a social determinant of health that has an adverse effect on infant mortality. So from that standpoint, that's true. It is one of many social determinants that contributes to poor birth outcomes.
And I ask these questions because I've just seen it as a funeral director, and I was trying to flesh out my experience with the facts. Where, you know, in my experience, obviously African American, being an African American funeral home, but locked in the cycle of poverty, because many times when there's a child death, I'm usually getting some donation from the county. A department sends a check to assist with the funeral plan. So again, locked in the cycle of poverty, and a single mother, and a younger, 18 or so, not always, but very seldom it's a two-parent situation. You know, so for me, that's just a visual that I get when I see it on a regular basis. You know, so my point, and then if I might, when I spoke with the CEO of Metro Health, he seemed to have a passion for infant mortality. Without any prompting, he asked the elected officials in the room, what could he do to help in terms of infant mortality? So because he opened up the conversation, I simply said, based on what I'd heard, 44128, the Lee Harvard area was a high infant mortality area. I say provide maternity unit services in South Point Hospital. You know, that's
Oh, I'm happy to hear that you said that, because it has been a challenge not having a delivery hospital in that community. The
Thank you.
majority of the
not Metro, but
participants,
Cleveland Clinic. Yes,
right,
Cleveland
served
Clinic.
by-
I did not mean Metro. Thank you.
For
I met with the
clarification.
CEO of
I
Cleveland
wondered when you
Clinic,
said
the
new
new
CEO.
CEO
Okay.
of Cleveland
Clinic.
I
Clinic.
thought I missed something,
Not
Councilman
Metro.
Jones.
Thank you for
Oh,
that.
yeah,
Cleveland
Dr.
Clinic.
Boutros isn't that new.
Yes,
Yeah.
and Jack was
Oh,
president, and
yeah.
Councilwoman, many on this
Yeah,
council were
got
present at that meeting.
Oh.
But CEO of Cleveland Clinic. And he did show an interest, a genuine interest, and he asked what he could do. So I shared with him what I thought could help.
That's a great suggestion. It's very much needed in that community.
Okay. What about the main campus if we're going to be greedy? So, thank you.
And Tron.
Because sometimes the numbers and things can get a little mixed up as far as what goes on with rates and percentages and things like that. And I'm glad to hear that the new head of the Cleveland Clinic was responsive to the question, because we were there when it was asked. But one of the questions what is the definition of live birth that we use here versus when we're sometimes compared to some of these other countries that they say they have so much lower of a rate? It's my understanding that some of those countries in Europe and places like that don't use the same number of days to determine live birth. That it's like 3, 4, 5 days before they have identified, and I'm not sure which countries, but France or Germany, do not even consider it to be a live birth until the child has survived for more than a number of days.
Well, the
It's
infant
one of the reasons in which
mortality.
they keep the numbers down.
These numbers, the calculated, are up to the first year of life, actually, for infant mortality. So if a baby dies before their first birthday, that's counted in the rate
he's
for
saying
us.
that the other-
I don't know, but just to
count the
clarify
births.
what this is, it's not live births. So
Okay.
you got, yeah.
I
So
thought we
it's-
were talking, okay.
No,
I
this
thought
is a
that
rate,
was-
infant mortality, the definition, which I think is universal. I think with the live birth, I've heard that too, but for infant mortality, it's death up to the first birthday. So for example, the unsafe sleep situations, which we continue to try to, address, are in here, which usually happens when the baby's, before 6 months old, but certainly well after the first few days of life. So it's prematurity and it's unsafe sleep situations that are the main reasons for the mortality.
So what we're talking about here is more of a training education component that's important to make sure that they understand. I mean, when we had our kids, you're supposed to lay them on your back, and now it's all on the front, I think, and
Opposite.
Other way around.
It was
Okay,
the opposite.
and you're
It's
supposed
changed a
to
few
not have
times.
any. You're supposed to
nothing
have
in the
curb
crib
things in
alone.
our cribs, and now you're not supposed to have nothing in the
Right.
crib. It's tough for grandparents to keep up with what the rules are.
So you would think that we could get the word out about the sleep, safe sleep.
Obviously, I didn't catch
We've
it.
been trying, well, no, I mean, we've been trying, the state's been trying, all of our home visiting programs are working on it. Typically, there's 16 to 22 deaths a year.
Richard told us that in 2016, there were 22 or 23,
Two.
and in 2017, it went down to like 13. So there's
It's
been a-
vacillating. We're hoping that's a
Yeah,
good
we're
trend.
hoping
We'll
that
see
the
if it
trend is
holds
going
up, but
down.
it's not just giving out cribs, because there have been situations where a crib is given. You guys give cribs. Our Welcome Home program gives, cribs, et cetera, but you have to use the crib appropriately. And the baby's left with other people, and not necessarily the mom or dad who's had training, or the grandma. And so that's the non-medical, you can say, part of this issue, but prematurity is the other huge and the bigger reason for the high rates of infant mortality. And just to one word back to your income question, so even middle-class African-American women have higher rates. And people have attributed that to higher levels of stress that they're experiencing. And another program here, which we're not funding, but Medicaid is supporting, I think you may have heard of Birthing Beautiful Communities, which is in Huff, right? Yeah, Huff. Are actually doing a test to look at cortisol levels, which is the stress hormone. It's all African American women, to see if the program, it's their doulas who support the women. It's similar to some of the other programs. Every program has a little bit different twist, but to see if they've been able to lower the cortisol stress, showing that they're really lowering stress. Because the question, what everyone's looking at now is are higher levels of cortisol that African American women experience affecting the pregnancy. So that's sort of the cutting edge research that's going on. So it's really interesting.
Okay,
But
all right.
people are trying to explain why, if you're middle class but Black, why are you also more at risk? And so they're looking for what's the mechanism there? I mean, certainly poverty has its own huge impact, but there's more to the story. It's a really complicated issue.
Okay, I thought
Yeah.
my colleague was talking about the infant mortality at birth when he was talking about it, and that's what I was just trying to get a definition as to.
It captures everything.
Up to
Pardon?
the first
It
birthday.
captures everything from pregnancy to that
Up
first
from
year.
pregnancy. That's why it's called First Year Cleveland.
Yeah,
Because it goes through the baby's first year.
Okay.
So,
Just another question. Why is Case Western Reserve always being used as the facilitator for the funding to pass through?
So that's
Do they bid
where-
on this, and do they charge us an admin fee?
No, this is because their first year Cleveland's fiscal agent, the medical school. And so this is actually, if I've got this right, crowd, the dollars actually flow first to them, then to us.
Okay.
And so they've applied as first year Cleveland to get the Medicaid dollars.
So we're not
That's
handing
why.
back to them, and they in turn are acting as the fiscal agent. Okay.
So they're the
backwards.
that's the fiscal agent for, the first year Cleveland staff and dollars are
Okay.
through the medical school. That's why.
Okay, thanks.
I know, this is the most confusing.
So, wait, can I just,
Flow of
so there's
dollars.
a contract between Case and the state, or?
So
Or
it
one
starts
contract.
with that.
Yes.
It starts with a contract between the state and Case, then Case with us, then us with the city, then the city with the providers.
Got it.
Oh, I'm sorry, there's another set of contracts with the managed care companies, sorry. It's a long and torturous road to get these dollars out to the community. That's why all these people are here. If you want to know all the tortured path, they can tell you.
Well, first, let's see if we have any, I think Councilwoman Brown has a question.
Thank you, Madam Chairwoman. Back to the 44128, which is a area code that I represent as on County Council, and it includes parts of Cleveland as well as Warrensville Heights. And so I've noticed just in Warrensville Heights, it is an aging population. So I'm curious if you guys are keeping records of the aging population. Women are aging out of being able to deliver children in that community, quite possibly, as well as Ward 1 is a part of that community. There's also an aging population. And then the transient component, you touched on apartment living. And so I'm just wondering also if some of those mothers are moving from one place to another, which has resulted in a reduction in the 44128 infant mortality. So I know you probably don't have that information, but I'm asking if you will, or if there is any possibility to consider those things.
Well, I know that, I don't know that transience has been looked at, but I know that the county's analysis is very drilled down, and I know that they look at the number that are working, employed, the number of college graduates, the number of, so that they look at age and they look at those other two things, and then they look at, like they compare the college graduate rate for people that live in that zip code versus, and how many of them are employed versus in other zip codes, and they're not faring as well, in other words. So they've looked at all these data. They've also looked at public transportation versus their own transportation. And there's a number of, I didn't bring that information with me, but they've drilled it down quite a bit. I don't recall transients, but I can certainly ask and inquire about that and make that suggestion.
Okay, yeah, just knowing that area and representing it, and knowing that there are a lot of the senior population is growing rapidly. I just wonder if that is a contribution. And lastly, seriously but not joking, in a way, kind of, sort of, do you have to be pregnant to get into the stress test program that you have? Because I'd love to be involved in learning ways to reduce stress for my life. So no, okay, all right.
I also, Warrensville Heights has actually its own special program focused called Moms and Babies First, which is funded by the state. And they're Warrensville Heights in East Cleveland, which uses a similar model, but that's delivered by Neon. And yeah, so that's delivered by Neon to Warrensville Heights. Because it's been, those two communities were seen as needing special assistance. So it's part of the crazy quilt that the state is funding different programs in different areas, but all for the same purpose.
And just point of clarification, you said, if I heard you correctly, you concentrate on the number of deaths in the community versus the infant mortality rate. Is that a safe thing?
Well, so we look at a combination of, right, the number of births, number of deaths, and then we do look at the rates, but we don't let the rates solely drive where we go, because, again, those rates could be misleading. If it's a community that has a low number of births, their rate could be driven up because they had just one or two infant deaths, whereas you could have a community with a lot of births and have a smaller amount of deaths, but have, or a larger amount of deaths, but have a smaller rate, is what I meant to say. That really needs the services more because there's so many more pregnant women in need of the services.
Okay, good to hear that. All right, thank you.
Thank you very much. It was informative. And so this effective date of the contract is January of this year, it looks like. So perhaps, are we looking at second reading suspension for this? I hear not seeing that from the gallery. So I can make a motion. I won't ask why. I'm assuming just your explanation.
If you want to know, we've got 5 people to explain to you what has happened.
Did you anticipate the question?
Yes, and we've been suffering through this process, unfortunately.
do you want to, anybody just, you came here, do you just want to give us a brief?
Marcos, here, let me give, yeah. We have a whole timeline.
Good afternoon, Marcos Cortez with the Office of Early Childhood. I do have a timeline here. It's not completely detailed, but it does spell out some of the things that occurred. We originally applied in early December of 2017 with the promise from the state that they would turn it around by the end of December. We didn't hear from them until the end of January, and it was buried in a press release. So once we found out that we were actually getting funding, we had to start the process of
Okay.
the whole contracting. And then there are 5 managed care agencies that are involved with this. Those contracts had to be negotiated between CASE and the 5 agencies. That took some time. And then their contract with us took some time. We had some issues with some of the formatting in the contract on our end, and that took some time to resolve. So as you can see, it took us all the way to June to actually get the contract submitted into the on-base system, and it was turned around pretty quickly once we got it in, but there was a whole host of different issues that resulted in this taking so long.
Thank you. Yeah, I mean, it's interesting you found out by the press release.
Right.
Yeah, I love that. Okay, so I'm going to make a motion to move this to the next full council meeting with recommendation of passage under second reading suspension.
Second.
All in favor? Aye. Any opposed? Okay, so this will go on to the next council meeting, August 7th. Perhaps one person may want to be here in case questions arise. And I will not be here, so I'm going to rely on my co-chair, Councilwoman Brown. So be ready. Okay, thank you. All right, thanks.
Just
Anything else?
one, just so, for the process, as you can see, we still have to bring forward the actual contract amendment that'll come before this
We
committee as
understand.
well.
Okay, great. We'll look for that. Okay, great. Thank you. Anything else? Bye.
Thank you very much.
I don't have miscellaneous business, and we can adjourn. Thank you.